Hello. Hi, everyone. It's so great to see all of you. And for those of you joining on YouTube, what are you doing? What could you possibly be doing at this hour that's more fun than hanging out with us in real time? Think about that. And if you have a good answer, congratulations. You're living a wonderfully healthy, fantastic, outstanding life. That you have something more fun to do at 9 a.m. Pacific time than to hang out with us. But I can't think of anything, especially because we have the dynamic duo of Vinny and Julia presenting a case again today. Vinny may owe you an explanation for why he looks so freaking cool right now. But first, let's leave that as a cliffhanger and thank everybody who's making this happen. And we have a dynamic duo scribing today. I'm not sure who's going to take the lead, but both VJ and Kuchal are slated to help. So maybe I can hand the mic to each of them respectively, starting with VJ, who has his video on first, and then maybe Kuchal if she can.
Hello everyone, I'm Vijay, one of the CP Solvers member. Happy to be back for an interesting RRR case.
Very happy to have you here, my friend. Kushal, can you say hi, or are you hiding on your Disney
Hey,
cruise?
hi everyone. Hi everyone. Happy to be scribing and helping out in today's session. And yeah.
Amazing. And then last but not least, Kritika, do you want to say hello before you dive into the teaching points?
Hello, Rabbi. Hello, everyone. Happy to be doing the teaching points today.
Incredible. Thank you. So nice to see you, Kritika. All right, Vinny, what's with the glasses and who's that person next to you?
Yeah, so hey everybody, I'm sorry I'm using wearing sunglasses. I just made an eye surgery, so I'll ask for a little bit of comprehension of all you all. And next to me, it's the love of my life, and that is helping me because I cannot read a thing. And yeah, she's doing the outstanding job of presenting for me. Yeah, thank you.
Incredible.
Hi everyone, I'm Julia. I'm a CP Solver member. I'm very excited for this case.
Julia, you're very, very kind. And Vinny, I would say that we should use this as a reason to start a new tradition where every time you present like this. That would be my hope and dream. What do you think, Rez?
Dude, I'm still stuck on the love of my life. I wish someone would speak to me like that.
I thought you were going to tell me that I'm your love of your life as a transition, but that's okay. We'll practice next time.
I should have said that.
You should have. That's okay. I forgive you. All right, Vinny and Julia, take it away. We're ready whenever you are.
Okay, so let's start with the first aliquot. This is a 74-year-old male was admitted to an outside hospital with generalized weakness and increasing low back pain for the last 3 weeks, as well as bilateral groin pain. He presented to our emergency department after his son raised concerns about his worsening back pain, bilateral hip pain, and difficult walking. And I will stop here.
Wow, this is really interesting. There is so much to unpack here. And what I'll do is actually, I'll share my reflective thoughts, but then pass the mic to Robbie to layer upon those. And Robbie, is my visual coming through right now? It is, okay, perfect. You know, when you get a bunch of symptoms and the patient is presenting, you have to be clever at where you decide to share your thinking and what symptoms are actually high yield. Lower back pain is really non-specific, and most individuals, when I say most, 99% of people with lower back pain will get better within the span of a couple of weeks. In fact, I have low back pain right now, and I'm sure many of you have experienced low back pain. But this is the part that gets a little worrisome. When you combine low back pain with groin pain and difficulty walking, I would honestly first start with the difficulty walking and back pain, because that suggests that you may have a myelopathy. And so I would be asking questions about bowel and bladder symptoms And the physical exam would be focused on eliciting signs of upper motor neuron disease like hyperreflexia or upgoing to Babinski. But the groin pain is interesting too. Can you have back pain and groin pain? The answer is yes, especially if you have something in the retroperitoneum that is withstanding pathology. In fact, renal cell carcinoma or kidney disease can shoot directly to the groin. So I think the more sinister possibility is something happening in the spinal cord, but the more realistic possibility is something that's happening in the organs in the retroperitoneum. But both are worth entertaining. And we have to start with the more serious problem being weakness and back pain. But not too many people with myelopathy will complain of groin pain. That groin pain has me thinking that something is referring pain into the groin from the retroperitoneum. But let me pass the mic to Robbie to layer above that.
I have nothing to add, Prof. Rez. Very comprehensive. Thank you for explaining why this is different than garden variety back pain and latching onto the groin pain being a very unique characteristic. I'm excited to see where we're going. Back to you guys.
So he was admitted to an outside hospital with generalized weakness and increasing low back pain for the past 3 weeks, as well as bilateral groin pain, as I mentioned. The pain was high intensity without radiation and was relieved with pain meds, but worsened with mobilization. He reported no acute changes in low back pain or right lower extremity symptoms for the past several months, although his right hip has been increasingly painful over the last several months. He has bilateral hip pain for the past 10 years and chronic back pain for the last 5 years, denies any recent falls or trauma. From the review of system, it's negative for fever, chills, nausea, vomiting, diarrhea, numbness, or tingling in his extremities. Also negative for new concerns with incisions, wounds, chest pain, or shortness of breath. From the past medical history, he had a severe rheumatoid arthritis, bilateral hip replacements, hyperthyroidism, prostate cancer, hypertension, and left lower deep vein thrombosis. He did several surgeries to his right lower extremity, requiring revisions due to a history of infection in the past, with the most recent revision in 2009. From the meds, he used methotrexate, doxycycline, levothyroxine, and prednisone, and not on any anticoagulation at home. He also recalls a previous hip infection, believed it should be on the right side, after his initial replacement. Since this surgery, he has persistent right hip pain, denies any current knee pain, but reports bilateral hand pain and bilateral metacarpophalangeal joint replacements in 2010 due to rheumatoid arthritis. He has used a cane for the past 7 years due to chronic hip pain, but recently he has worsening difficult to ambulate for unknown periods.
Yeah, so just to summarize, you have in front of you like a patient with history of severe rheumatoid arthritis who had metacarpophalangeal replacement, bilateral hip replacement, bilateral knee replacement, and revision, a lot of revision surgeries from complicated infections and so on, and also the chronic pain.
So that's the end of the second quote.
Yeah, man, I think it's so powerful what has changed as we've gotten to know this patient, which is that the history of the aforementioned areas is much more long-standing. And I think when somebody has such a long-standing history of MSK disease, naturally the amplitude of the concern for today will be decreased because there's so many plausible mechanical reasons as to why he might be in this discomfort. And I also think that unfortunately, the cumulative morbidity of all the things that he has experienced can add up and trigger a vicious cycle where the patient's in relentless progressive pain. And I think here, the things that have changed are that because his hips are replaced, the probability of metastatic disease to his hip is gone. There is no bone there for the cancer to take over. And the probability of highly concerning infections is also gone. And I think that latter part probably deserves a little bit of explanation because prosthetic infections of the hip are very cumbersome, very hard to diagnose, and very problematic, but the consequences of them are much less. And what I mean by that is because the patient's hip has been replaced by foreign material, the main consequence we worry about with septic arthritis, namely destruction of the native bone and synovium, has already occurred and has already been replaced. So the reason we care about prosthetic hip infections is that they result in mechanical dehiscence of the hip, but that usually takes weeks to months. So what's happened in my mind, Prof. Rez, is knowing that he's had extensive surgeries and replacements and whatnot, I now realize that this tissue is very vulnerable, and a minor insult may be accounting for the degree of dysfunction, no different than somebody with dementia coming in and being confused. This degree of consequences that he's had here makes it very, very similar. So I think I'd be really curious to see how much of the disease rises at the surface. And I think many instances like this we take care of where the back and the hips are hurting patients, and we do a good exam to make sure there's no serous pathology. We get basic labs to ensure that there's no unrecognized systemic inflammation. And most patients, unfortunately, are stuck in a vicious cycle of pain. And I think it's very important to acknowledge that as a possibility in real life very quickly and not to pursue aggressive diagnostic testing. But it's also important to acknowledge the reality that just because he has a long-standing history of problems in this area doesn't mean he's not vulnerable to new acute disease. And I think both those pathways are possible. So in real life, I'd be very open to a reassuring exam and a pristine set of labs, including a normal ESR and CRP, and focusing on how to manage this patient given his difficult consequences. But I would also be open to the fact that that pathway is possible, but it's not written in stone. Any other thoughts, Prof. Rez, that you want to add in?
Man, I think that was so beautiful. And bottom line is, I think you, Robbie, me, and the audience, we're really struggling to not only frame the problem, but more importantly, relate the problem to the past medical history. Because the past medical history is so complex and intricate. And the best thing you can do in this circumstance is not ignore the past medical history, but just focus on the main problem. And if this person had no past medical history, how would you approach it? And then layer in the past medical history and see how that affects your differential diagnosis. So effectively, Robbie, what I'm doing is creating two PRs. One that's much more simpler with removing all this past medical stuff and focusing on the chief concern. And then a second PR that then layers it on to expand rather than narrow or hyper focus the DDX. This doesn't always work, but in a case like this, I think it's necessary. Otherwise, I'm just too overwhelmed on trying to make connections behind all of these joint replacements and long hospitalizations to his current. So I think our goal right now, let's just see what is the problem. Like, where do we want to focus our energy on? And I think the exam, the labs, imaging will help refine that problem for our brains to solve. And then we layer on that difficult past medical history.
So going through the physical exam, the vitals look fine, blood pressure 120/80. He had one episode of fever of 38 within the hospitalization, but now febrile. He's ill appearing, hand normal, cardiovascular normal. From the extremities, there's ulnar deviation of the fingers on both hands, radial deviation of the wrist on both hands, also edema and area of redness in the right hip joint, pain and mobilization of this joint, and preserved mobilization of the left hip. Pulmonary, abdominal, neurological, all normal. Going to the labs, white blood cell count of 10.8, which is normal. Hemoglobin of 10.5, which is low, with hematocrit of 31. Sodium of 132, potassium normal at 30.8. Chloride normal, BUN and creatinine also look normal. Total protein of 5.5, calcium of 8.3, alk phos of 304, and AST a little bit elevated at 86, but ALT normal. Also, this white blood cell that is 10.8 now is decreased from the previous hospitalization that was 15. CRP was 22 and ESR 49.
Yeah, other than that, the patient does not have any history of drug use and neither alcohol and no allergies, no family history that is pregnant. And yeah, we'll stop here.
Okay, so maybe I'll focus on the exam and then ask Robbie to comment on that and the subsequent labs. You know, we're still looking for a signal, and we may have got, and that is the fever this patient had. But, you know, if I'm being honest, like in the hospital setting, if you have like one fever, people tend to go crazy. But in reality, you have to be calm and be cautious about like how aggressive you work it up. But fever is the most specific finding of inflammation. So in my mind right now, I'm labeling this individual as inflamed. And whenever we do that, then we go through the most common causes of inflammation, starting with infection, and then later on focusing on malignancy and autoimmune diseases. Once you say inflammation, once you say infection, then you have to try to zoom in to the source or the site that's driving the inflammation. And sometimes you don't get a signal for that on physical exam. Other times you do. And here, you have to be able to separate what is acute on onset versus what is chronically there. Like ulnar deviation didn't happen overnight. That's a chronic finding. But this redness and swelling at the right hip seems to be acute. So now, my concern is, could there be an infection of that prosthetic joint that this patient has? The difficulty in mobilizing this joint may be something that he chronically experiences, and it's important to clarify that with the patient. But at the end of the day, when we talk about a septic joint, we talk about range of motion, and we talk about effusion or swelling, and we talk about systemic signs of inflammation like fever. So for me, right now, the do not miss is something happening in that right hip, and the hip joints, they sit back in the body. So sometimes they have nothing on physical exam because they're deep joints, and you can't exclude infection of those joints by the physical exam because they're so deep. You actually have to investigate further because their pathology may not rise to the surface. So Robbie, I'm gonna pass you the mic, but for me right now, we got this gentleman, complicated past medical history, coming in with subacute symptoms, back pain, hip pain, radiating to the groin, had one-time fever, and then on exam, seems to have edema and erythema of that right hip.
Yeah, I love it, Prashraz. Yeah, I'll just flying through the labs. I think my major impression with the labs is that the amount of inflammation is not through the roof, but certainly present. And I think in this situation, when you're trying to move past an acute dynamic problem, you really need completely negative inflammatory markers. and the predictive power of completely negative inflammatory markers in patients presenting with back or hip pain is through the roof. So I think you have to acknowledge that, especially in the context of the fact that the right hip is also red, that these markers of inflammation reinforce what you're seeing on exam and heighten the concern that there might be an inflammatory process in that area. But you have to, at the same time, acknowledge that the white count is better than before. And so it's, I think, very, very evocative if there is an infection of the kind of infection that you'd be entertaining. In patients with acute septic arthritis of the hip, they're acutely sick, always febrile, and getting worse. The indolent infections that infect and affect prosthetic material are often of this nature. They're fastidious, hard to grow, and cause a very indolent, slowly progressive syndrome. So I would definitely reinforce that. What isn't in keeping with an infection is the patient's elevated alk phos. And as you may know, alk phos really comes from two primary sources: the liver and or the bone. And the first clue to where it's coming from is to see if the patient has other liver enzyme abnormalities. And here he does, technically. His AST is high, and so you wonder, is it coming from his liver? But in parallel, we're solving a case of bone pain, and so the fact that his hips and his back are hurting is a counter argument to that. So I think it's ultimately dealer's choice as to where you think it's coming from. You could get a GGT to help you figure out if it's hepatic in origin. But I think the trend would be very, very helpful. I just wanted to emphasize that not all bony diseases cause alk phos elevation. Alk phos elevation is a marker of blastic activity of the bone and would not be consistent with an infection. Infections are so lytic to the bone that all cases of osteomyelitis, with very few exceptions, result in no alkaline phosphatase elevation. So an alk phos is driven by a process that breaks the bone, but also allows the bone to heal. Infections don't do that. And so another cancer that doesn't do that is multiple myeloma, very aggressive, very lytic, and really takes over the bone. And so I'd be curious what the trend of the alk phos was. Is this a new or is this a chronic issue? But definitely in the context of the bony disease that we have, you have to pay attention to it. And also, of course, since he has a history of prostate cancer, and the idea of metastatic prostate cancer would certainly be crossing our minds and triggering a PSA in this patient. So a lot of things to try to explore. I think the alk phos trend is key, and then taking some pictures of the back of the hip and helping us figure out where things lie.
So, all right. Unfortunately, we don't have the alk phos from the past and even the GGT to compare. But I will give some labs and image from the outside hospital. From the outside hospital, they did an MRI of the bilateral hips at outside some weeks prior, which was negative. Blood cultures at this outside hospital showed staph areas, so he was diagnosed with bacteremia. And the right hip aspiration at this outside hospital was negative some weeks prior. So I will stop here.
Yeah. So they performed the like try to investigate the source of the bacteremia in the other hospital, and but they couldn't find it, and they did the MRI in order to investigate that, and also to the decrease in mobilization of the right hip, and they tapped it, but they, as Judith mentioned, came a tri tap, and then we still have the like an unclear source of the bacteremia. So then he was transferred to our hospital. So yeah, what do you guys want to do right now, and how you guys got this case? Yeah.
Yeah, I think the finding of Staph aureus bacteremia is very, very concerning, and I think it readily explains many of the things, the fevers, the discomfort. And I think the first question you think about with Staph aureus is, where did it come from and where did it go? And very often you don't find out where it came from. It's often a skin source and there's no clear signature. And now you have to pay attention to where it went. And I think the rate of endocarditis with Staph aureus bacteremia is about 25%. That's why in all comers, a transthoracic echocardiogram is recommended, and in some people, a transesophageal echocardiogram is recommended. In this patient who has low back pain, I think you also want to make sure that he doesn't have osteomyelitis or an epidural abscess of his lower back. And yeah, and I think that would be relevant because the patient also has hip pain, and while he doesn't have any disease in his hip radiographically, he could easily have referred pain to his hips, especially bilaterally. So remember that the L1 to L2 L1 to L2 myotomes refer to the hip. But also prosthetic infections are notoriously difficult to diagnose, and so you may need to repeat the MRI. So Professor, what I would be doing honestly is repeating his blood cultures, looking up sensitivities to decide whether I should treat him with vancomycin for MRSA or cefazolin for MSSA, getting a TTE and getting an MRI of the back. At the same time, I'd probably be reassessing his hip and doing a good exam to see if we need to repeat his MRI of his hip. What are you thinking?
My God, I agree 100%. I'm just surprised you didn't sing the song. You know the song, but you didn't sing it. Shame on you. But I was just gonna say this, Robbie. We were like, this was such a difficult case at the onset, but now we really do have our pivot point, and everything becomes about this Staph aureus and this guy's vulnerability to seeding multiple sites because of his history of RA, the history of procedures that happened, and yeah, so very, very good.
So we are about to reveal the diagnosis. Do you want me to proceed?
Yeah, go
From
for
my
it. Go for it.
perspective, please, because I have nothing else to say.
Okay, so they did the TT, which was negative, and the patient just had one minor criteria from the Dukes. They did also the blood cultures again. They did reveal Staph aureus again.
And yeah, at this point, when it was repeated, the blood cultures, it was discussed with IED, and they suggested just to treat it with oxacillin. And yeah, there was a discussion to try to escalate for vancomycin, but due to the patient having presumably acquired this infection before the hospitalization, and it was not from was not concern for MRSA, and they just decided to cap the oxacillin, and yeah.
And then the repeat CT reveal total hypertrophy and acetabular reconstruction with large gas containing joy effusion and continuous fluid collection in the upper thigh, as well as multifocal periprosthetic lucencies. And also radiology was consulted, and they indicated ultrasound guided aspiration of the right hip. And in this time, did reveal 20 milliliters of purulent fluid.
Yeah, so basically, as you said, Ravi, I didn't know at that time that it is so hard to diagnose and to see the periprosthetic joint infection, and presumably I was thinking that this patient already has the MRI, and why we're not seeing, and there is physical exam like that is compatible with the history. The patient has severe risk factors for developing a periprosthetic joint infection. It's not the first time that he did that. And despite all those factors, like the imaging couldn't see, and that's intrigued me the most when I saw the case. And one more time, when you perform a test and it came back negative, you must repeat it again if you're very confident about like your diagnosis or the patient has a lot of risk factors, and you have a high pretest probability of diagnosing that disease. So it in the end was per prosthetic joint infection.
I love this. I love this case, and because I think we ended a little early. Maybe, Professor, if you're okay with it, maybe you can just do a three to 4 minute breakout room for people to reflect and chat about this, and then maybe you and I can share our reflections or any pieces of advice. How does that sound, Professor? Awesome. Okay. All right. Hang tight. I'll help pause it. There you go.
So I have a question for my YouTube audience. Who wore it better? Of course, Vinny did, but just entertain me. For those that hate me, say Reza wore it better in the comments below. All right, Robbie, my team.
Oh, come on, man. Come on. You look good. You're great. You're stylish. You're the one and only Prof. Rez. But let's hear your medical wisdom too.
Okay, let me get these back on. So I think that Vinny, this case by you and Julia was just outstanding. Why? Because it married bread and butter with something unique. Bread and butter being just Staph aureus bacteremia, inflammation, but something unique being prosthetic joint infection. And really learning that even though Ravi had a great illness script for prosthetic joint infection, let's say we were worried about osteomyelitis of the back or an epidural abscess. Even if the MRI is negative, it could be that it was done too early, the gadolinium wasn't timed correctly, or it just wasn't read properly. I've been in that case before. So when you get a study and it's negative, it could either be a true negative or it can be a false negative. This is a very important concept to understand in medicine, and I hope that all of you understand it. Did you see that, Robin? Or you're not looking at me?
Oh, I'm staring at you, Prof. Rez. The love of my life. Oh my gosh. My reflection is actually latches onto something that Jillian said in the chat about the prednisone. And I think we do a very good job of expressing and teaching the idea that when somebody is immunosuppressed, they don't have the ability to tell you vigorously how sick they are. And I encourage all of you to think about prosthetic material as exactly the same. The only difference between prednisone and prosthetic material is prednisone causes a systemic immunosuppression, but prosthetic material locally in and around the joint has no immune system. Do you guys know what the cutoff is for cell count for septic arthritis of prosthetic joints? It's way less than septic arthritis of native joints. Way, way, way less. Why? There's no immune system. There's no macrophages. There's nothing. And so it's very, very common for the diagnostic data, imaging, cultures, so on and so forth, to be incredibly, incredibly slow and difficult to maintain. I have never had a patient who ultimately was diagnosed with prosthetic joint infections be diagnosed on the day they presented. Never. That's always this high maintenance of suspicion, and you just have to wait for the disease to declare itself. Just 2 weeks ago, we had a patient who had 6 months of suffering before he finally was diagnosed with prosthetic knee infection. And he was like, it's not feeling right. And slowly every x-ray showing that the prosthetic material was dehiscing. And then finally his culture came back positive. So it's very, very difficult diagnosis to make. So treat these patients no different than you treat an immunosuppressed patient, except their immunosuppression is unique. It is a local immunosuppression. And so it causes an indolent, slowly progressive disease that reinforces to us how much we rely on a healthy immune system for the fire alarm to go off in the patient's body and for our tests, because our tests are just as proportional to the body's response to the problem. So I think this is an excellent, excellent demonstration of that fact. Thank you so much, guys. Really, really appreciate it. Maybe we can hang the mic to you all to share your reflections, and then last but not least, to Kritika for the teaching.
Yeah, no, I just appreciate all your comments. And when I first saw the case, like the discussion was between like escalating or not escalating the antibiotics, and if the attending and all the team was comfortable treating with just the oxacillin and confident about it. And other than that, the value and the importance of history. So the patient, as I pointed out, had a lot of risk factors, a severe rheumatoid arthritis with a very complex past medical history, not being the first time of a periparasitic infection. And all this culminates for a high pretest probability for what you're suspecting to this case. And despite the fact that the first test came back negative, you should move on and repeat the test and repeat cultures. And that's a thing that I truly give the value after like being part of CPS and valuing more the history and repeating as much as necessary the labs and the imaging. So thank you so much for the opportunity to present the case.
Hopefully the glasses live on forever, Vinny. All right, Kritika, Mike, to you. Take it home.
Thank you for the amazing case, Vinny and Julia. And thank you for the great discussion, Rabih and Dr. Reza. So today we had a patient who was a 74-year-old male who came with low backache, bilateral groin pain, and difficulty in walking. So Dr. Reza mentioned that we can consider a possibility of myelopathy, and we need to ask for a history of any bowel or bladder involvement, hyperreflexia, and plantars which can be extensive. And here we had a combination of low back pain with groin pain. So that could point to a retroperitoneal cause. And because this patient had a hip replacement, so it's a possibility of prosthetic infection of the hip was considered. And Rabih mentioned that it is generally difficult to diagnose, but the consequences are generally less severe as compared to the normal hip joint. And the organisms that cause indolent septic arthritis are generally fastidious and they cause a slow progressive infection. And in this patient, we also noticed that there was an elevated ALP cause. And Rabih mentioned a very good point that it could unlikely be a metastatic cause because it is a prosthetic joint. And also the possibility of osteomyelitis is also very less because generally ALP cause is elevated in osteoblastic conditions and very unlikely to be elevated in this condition. And we also mentioned that the risk of infective endocarditis with Staph aureus is 25%. And also the cutoff for cell count for septic arthritis is generally low compared to a normal joint because the immune response around the prosthetic joint is very less. So it is very crucial to be evaluated properly before diagnosing. Thank you.
That was phenomenal teaching, Kritika, concise, to the point, and powerful. You summed it up better than Rabih could have himself. Thank you for that. And thank you, Vinny, Julia, and everyone for joining us. This was another edition of RLR. Rabih, hit them with your signature. Goodbye.
Goodbye.